Uh, Thank you, Krishna, and thank you, Rosh. So today we'll be discussing regarding cancer immunotherapy or CIT and role of tecentriq in second line metastatic non-small cell lung cancer. So basically, we'll be discussing regarding the role of immunotherapy and how the treatment evolved for lung cancer. And later on, we'll be focusing on the indication of tecentriq in metastatic non-small cell lung cancer, mainly in second line. So I think this slide we all are very familiar with. We all know that lung cancer is one of the leading cause of cancer mortality worldwide. And the latest Globocan data also suggests, the 2020 data also suggests the same. The estimated worldwide incidence in 2018 was around 21 lakhs in both males and females, and it was the cause of the highest mortality, around 17 lakhs, and this is the worldwide data. Before we had the chemoimmunotherapy, the 5 year survival was very low for non-small cell lung cancer, especially stage 4. After the introduction of targeted therapy, the survival drastically improved. And now we have immunotherapy for patients who are mutation negative also. So you can see that the overall 5 year survival was 1.5%. Hardly there is any patient that usually goes beyond 1 or 2 years, but before the introduction of chemoimmunotherapy. uh, uh, Based on histology, squamous profile had a 5 year survival of 1.6%, adeno had a 5 year survival of 1.5, large cell had 1.1, and adenocarcinoma had 4.4, adenocarcinoma in situ. So we can understand that this 5 year survival was very low. So the birth of immunotherapy started way back in 1891, and during that time, around 1893, there were many papers published by Dr. Colles. He used Streptococcus bacteria and used the toxins of this bacteria to treat many incurable bone and other sarcoma patient. So he published case series and case reports, and during that time he had a theory that increasing the immunity of the body, and by improving the immunity of the body to fight cancer, can ultimately cure cancer. But his study was later on criticized by many scientists during that time, and later on the evolution of chemo and radiotherapy started, and after around 120 years from now, we have now again discussing about the cancer immunotherapy in these sets of patients. So he basically worked in New York and mainly dealt with bone and soft tissue sarcomas. So, briefly describing the history of chemoimmunotherapy, around 1860 to 1990, there were discovery of immune infiltrates in the tumors. They were observed, and certain bacterial products like Streptococcus or their toxins were inserted. And in 1970s, dendritic cells were discovered. In 1990s, human tumor-associated antigens were characterized. CAR T cells therapy were in the initial stages. And from 2000 to present, we have multiple mechanisms and multiple pathways that have established the role of immunotherapy in oncogenesis. We have studies in adoptive T cell transfer. We have studied in IDO inhibition, CTLA4 pathway, PDL1, PD1 pathway, CSF1R pathway. So what we have learned that immunotherapy is one of the important rate limiting step to effective anti-tumor immunity. And this is also one of the hallmarks of cancer. So we have identified this step, and we have tried to target it and to identify various methods to act on the cancer cells. Some form of immunotherapy mechanism that are blocked, and some of the drugs that are available, like vaccines act on the antigens, and we have anti-CTLA4 like ipilimumab, which acts on the steps of initiating and propagating anti-cancer immunity. And then we have anti-PDL1 and PD1 inhibitors like nivolumab, pembrolizumab, tecentriq, durvalumab. They act on cancer cell recognition and initiation of cytotoxicity. Basically, these are the mechanisms that have been developed and that have been targeted so that we can basically halt the cancer progression and probably kill the cancer cells. So the important pathway that we have to discuss before coming to the next slide is blocking the PDL1 PD1 axis. blocking the PDL1 PD1 axis, what does it basically do? It basically restores or prevents the loss of T cell activity that is induced by the tumor. PDL1 and PD1 interaction inhibits the T cell activation, which attenuates the effector function, which maintains the immune homeostasis. Tumors in surrounding cells they regulate the PDL1 in response to T cell activity, and blocking the PDL1 and PD1 restores or prevents the loss of T cell effector function. So we have it has been established that multiple in arrays of solid tumors and in hematology also there is activity of anti-PDL1 and PD1 in human cancers. For example, in multiple cancers, we have proven role of immunotherapy like head and neck cancers, lung cancers, liver, melanoma, renal, bladder, colorectal, and many more. PDL1 expression is regulated by different mechanisms which happens in the tumor microenvironment. There are two basic mechanisms. One is the adaptive PDL1 expression. The other is the constitutive PDL1 expression. The adaptive means that PDL1 can be induced by an adaptive response by certain inflammatory signals such as interferon alpha, interferon gamma, taking advantage of the natural mechanism designed to protect tissue from immune-mediated damage. And the tumor-infiltrated immune cells rapidly upregulate PDL1 expression in response to interferon gamma. Constitutive PDL1 expression means that PDL1 can be induced by constitutive oncogenic signaling, resulting in overexpression of PDL1 on tumor cells, and it can be driven by cancer cell intrinsic alterations associated with carcinogenesis, like in Hodgkin's lymphoma. And constitutive PDL1 expression is independent of the inflammatory signals which are present in the tumor microenvironment. And PDL1 is broadly expressed in multiple tumor types. Prevalence of PDL1 expression in immune cells is higher than the tumor cells across various tumor subtypes. For most tumors, immune cell staining incorporates tumor cell data is not shown except in non-small cell lung cancer, where unique IC and TC subpopulation exist at each PDL1 expression level. So we need not go to detail in this slide. So targeting PDL1 and PD1. So anti-PDL1 drugs, what do? The targeting of PDL1 can block the co-inhibitory signaling between the tumor cells and both PD1 and B7.1, preventing ultimately the downregulation of T cell activity. And anti-PD1, it acts by targeting of the PD1, blocks co-inhibitory signaling between the tumor cell and the PD1, sparing the interaction between tumor cell and B7.1. Now, efficacy of PD1 inhibitors in previously treated non-small cell lung cancer. Nivolumab was the first immunotherapy drug that was established in second-line non-small cell lung cancer on the basis of CheckMate 57 trial. So, PD1 inhibitors in previously treated advanced non-small cell lung cancer. So, nivolumab was evaluated in non-squamous and squamous histologies both, and patients were randomized to the standard of care docetaxel to PD1 inhibitor. So, CheckMate, this slide is discussing the results of the CheckMate 57 and CheckMate 17. And in this graph, you can see that nivolumab had a superior overall survival with significant survival benefit, 12.2 months as compared to 9.4 months in the docetaxel arm with a hazard ratio of 0.73. And in the squamous histologies, CheckMate 17, we know that squamous carcinomas, they do worse as compared to adeno. And it showed that the survival was, although more, it was 9.2 months in the nivolumab as compared to 6 months, but it was less as compared to non-squamous histologies. Coming to the 1 year and 2 year overall survival of CheckMate 57, the 2 year survival was 29% favoring the docetaxel arm as compared to favoring the nivolumab arm as compared to 16% in the doci arm. And in the squamous histology CheckMate 17, the 2 year survival was 23% versus 8% in the docetaxel arm. The overall survival benefit with nivolumab was independent of PDL1 expression in patients with squamous histology. You can see from this forest graph that the PDL1 expression did not matter in second line nivolumab when it was patients were treated with squamous histologies. However, in patients who had non-squamous histologies, patients who had low or no PDL1 expression in the subgroup analysis, they did not derive significant benefit as compared to the chemo arm. Now, coming to the molecule tecentriq, we'll be discussing the efficacy of tecentriq in previously treated non-small cell lung cancer and what are the indications and what is the present data. So we'll discuss the phase 3 OAK trial. So phase 3 OAK trial was published in 2017 in Lancet. So it is the efficacy and safety of tecentriq in previously treated non-small cell lung cancer. So it was a randomized trial and included locally advanced or metastatic non-small cell lung cancer who were previously treated with 1 or 2 lines of treatment and had at least one platinum-based treatment. And irrespective of the PDL1 status, patients were randomized, and it also included CNS metastasis patient. So patients were stratified into tecentriq 1200 milligram every 3 weekly versus docetaxel 75 milligram per meter square every 3 weekly. And on progression, it was a crossover trial. So primary endpoint was overall survival in the intention to treat patient, and overall survival in patients with a PDL1 expression more than 1%. So this trial basically demonstrated a statistically significant and clinically meaningful improvement in overall survival versus docetaxel in previously treated non-small cell lung cancer patient. So you can see from this Kaplan-Meier graph that the overall survival favored tecentriq 13.8 months versus 9.6 months in the chemo arm. And the hazard ratio was also very good, 0.73, and that was statistically significant. And in this slide, what it is trying to show that irrespective of the PDL1 expression, so tumor cell 3 or IC3 means that the expression was more than 50% in the tumor cells, or it was more than 10% in immune cells. And TC2 and 3 means that it is more than 1% or more than 5%. So and TC0 and IC0 means that PDL1 expression was less than 1%. So this forest plot showed that irrespective of the PDL1 expression, tecentriq showed a better survival. In patients who had a PDL1 more than 50% or immune cell more than 10%, that is TC3 or IC3, the median OS was 20.5 months versus 8.9 months. And in patients who had no PDL1 expression, that is less than 1, then also the survival was 12.6 months versus 8.9 months. So, and the 2-year survival was also better with tecentriq arm. It was 31% favoring the tecentriq as compared to 21% in favoring the chemo arm. And the important point to know that even if the drug is stopped, the median duration of response was more than doubled with tecentriq as compared to dosi. So even if we are not able to give the immuno for longer time, the median duration of response is still maintained. It was 16.3 months favoring the tecentriq arm as compared to 6.2 months in the chemo arm. And in patients who had PDL1 expression, that is TC123 or IC123, it was 16 months versus 6.2. And in patients who had no PDL1 expression, the response was not evaluated in tecentriq arm. It was similar 6.2 months for the chemo arm. This is just an example of how wonderfully can immunotherapy works in certain subset of patients. So this patient was, the left hand scan showed the baseline scan. Patient had significant GGOs, bilateral lung mets, and after these 6 weeks of tecentriq, it showed great improvement. And by the end of 14 months, patient had almost near CR, and that response is still maintained after close to 3 years. So in those patients in which these molecules, the immunomolecule works, the response is sustained. So skip this slide. So the benefit of overall survival was present in all the clinical subgroups in patients, whether they were smokers or non-smoker, whether they had a baseline CNS mets or CNS mets were not present, and irrespective of the age, even this patient, this subgroup have had patients who were more than 65 years. In these patients also, the data favored the tecentriq arm. So when you treat patients with cancer immunotherapy in your practice, how long do you generally continue treatment? So actually there is no answer to this. So there is a data of nivolumab which has shown that stopping nivolumab after 1 year as compared to 2 years, the data favors the 2 year arm. So if at all you need to stop the drug, I think the ideal duration as of now it's 2 years if the patient is doing well with the immuno drug. And the other answer is beyond disease progression. If the patient is on immunotherapy drug and is showing clinical response, is benefiting from it, and there is doubtful response in the CT or the PET scan, then there is option of continue immunotherapy drug till the patient derives clinical benefit, because the median duration of response, even in progressive disease, it's still more in the immunotherapy arm. In OAK trial, patients could continue tecentriq after radiographic progression. So that is what I discussed based on the protocol defined criteria. So in the OAK trial, tecentriq was continued provided evidence of clinical benefit was there. There was no signs or symptoms suggesting disease progression, and there was no decline in patient's performance status, and no tumor growth at critical sites like leptomeningeal mets. And patients with approved alternative therapies acknowledge deferring these therapies via informed consent form. So tecentriq beyond progression is associated with clinical benefit. Target lesions, they response observed beyond the RACES progression. So best response in target lesions for patients in the tecentriq arm included in the post progressive disease analysis, that even if there is progression, there is some data that we can continue this drug if the patient had clinically benefit, have some clinical benefit. You can see that even if we continue, there is few subsets of patients that may actually develop a partial response, and majority of them will remain stable, and around 43% patients can develop a progressive disease. So in case there is no further subsequent options and the patient is doing relatively well, then we can continue with this molecule. And tecentriq beyond progression is associated with clinical benefit also. The median OS for tecentriq post-progressive disease was 12.7 months as compared to, and the 18-year overall survival was 37%. As compared to other anti-cancer drug, if they were given, the median OS post-progressive disease was 8.8 months, and it was more in tecentriq, around 12.7 months. And the overall survival curve stayed separated post-progressive disease, despite patients in the standard docetaxel arm receiving the post-progressive disease immunotherapy. So that means that the median duration of response is still maintained in the immunotherapy arm. So now we have the updated results of the OAK and the POPLAR trial. POPLAR trial is also a phase 2 study which compared dosi with tecentriq. So in both these studies, the 4-year overall survival still favored the tecentriq arm, around 15 to 16% versus 8% in the docetaxel arm. So this was presented in ESMO 2020. So coming to the same 4-year overall survival, you can see that in the intention to treat population, the response rates was also more, around 16% as compared to 9%. And in both non-squamous and squamous histologies, the data favored the tecentriq arm. Around 19% response rates was there as compared to 10% in the non-squamous, and in squamous around 9% as compared to 5%. And in patients who had a high PD-L1 score of more than 50% or immune cells more than 10%, that is TC3 or IC3, the response was relatively more, the OS rate was more, the OS rate was more, the 4-year overall survival rate was more, 33% versus 15% in the TC3 or IC3 arm. And in patients who did not have PD-L1 mutation, still the overall survival rate at 4% was 15% favoring the tecentriq arm versus 7% in both these trials. So both POPLAR and OAK trial had a almost similar results, and all these results, the 4-year overall survival, irrespective of the histology, squamous, non-squamous, and irrespective of the PD-L1 status, favored the immunotherapy arm. So it's just wonderful to see that if a patient have a high PD-L1 percentage, the 4-year survival is 33% for a stage 4 lung cancer, as compared to 15% in patients who had a high PD-L1, and this was the second line data. Overall survival, this is the graph showing the overall survival in PD-L1 high TC3 or IC3 and PD-L1 negative, that is TC0 and IC0 subgroups in the Poplar and the Oak trial. So you can see in all these graphs, especially the first two graphs, that how beautifully these graphs separate after around 2 to 3 months of treatment. And all these favored the tecentriq arm. This was in both the trial was around 28 and 33%, and it was around 10 to 15% in the chemo arm. And in the PD-L1 negative subsets also, the response was maintained after 4 years, favoring the tecentriq arm around 15% versus 7% in the chemo arm. Treatment duration, treatment beyond progression, and crossover and subsequent non-protocol treatment among 4-year survivals in Poplar and the Oak. So continuation of the same trial, the median months of duration in the Poplar trial was 26.5 months with the tecentriq, and in the Oak trial it was around 35 months, that is around 3 years of tecentriq as compared to around 6.2 months and 4.2 months for dosi. And patients continuing treatment beyond progressive disease, around 8 patients out of 15, 53 patients in the Poplar study continued treatment beyond progression, and around 18 out of 43 patients in the Oak trial continued tecentriq beyond progression. And the crossover was allowed in both the study, and the patients who received subsequent therapy was around 67% in the tecentriq arm in the Poplar study, and around a majority of the patients in the chemo arm received second line treatment, the third line treatment. And subsequent anti-PD-L1 and PD-1 antibody, that is immunotherapy, that was given in close to around 50 to 60% in the chemo arm. So it was a crossover, both were crossover study. The majority of the patients who progressed on docetaxel arm received immunotherapy. So in Poplar study, 7 of the 15 patients in the tecentriq arm and 3 of the 4 patients in the docetaxel arm were responders. In Oak, 24 of the 43 patients in the tecentriq arm and 11 of the 26 patients in the docetaxel arm were responders. In Poplar and Oak, 8 of the 15 and 19 of the 43 of the 4-year survivors in the tecentriq arms respectively were non-responders, which included long-term survivals with stable disease or progressive disease as best overall response. So you can see from this table what I discussed, the percentage of response. Coming to the adverse effect profile of tecentriq, so as we are towards the learning curve of immunotherapy, so we are now used to manage what are the immune related adverse events. So obviously the adverse events were different in the tecentriq arm as compared to the chemo arm. So in both the Poplar and the Oak study, all grade adverse events were around 15%. Almost 100% patients had some form of side effects in the Poplar study, and 97.7% had some type of adverse effects in the Oak study. And grade 3, grade 4 adverse events due to any cause was around 53% in the Poplar and around 44% in the Oak trial. And serious adverse events were 46% in the Poplar and around 30% in the Oak study. And adverse events leading to treatment withdrawal were around 13% and 16% in both these studies. And adverse events leading to drug interruption were around 40% in the Poplar study and 50% in the Oak study. So there were no grade 4 or 5 events in the Poplar study. So majority of these side effects are manageable. So we should understand and monitor the parameters like thyroid profile, LFT, and cortisol levels, and ask the patient questions. So So whenever we feel that it's probably because of immune related, it's better that we hold the drug, and if needed, we need to start the patient on steroids, and we have to wait for that the side effect to go to grade 1 before we can re-challenge. And there is one problem that I face with immunodrug, that there is no dose reduction level that is mentioned in the literature, that once we need to decrease the level of dose, I'm not sure how do we decrease it. So coming to the conclusions of the Poplar and the Oak study of the 2020 updated results, long-term follow-up of the randomized Poplar and the Oak studies through a 4-year period suggests a greater survival benefit with tecentriq as compared to docetaxel in previously treated patients of advanced non-small cell lung cancer. That is irrespective of PD-L1 expression levels or histology. And the majority of patients, more than 50% of the patients of the docetaxel arm, received immunotherapy in the second line, and those, especially those patients who are surviving beyond 4 years. Radiographic response is not a requirement for long-term survival benefit, as some of the 4-year survivors in the tecentriq arms of each study were those with progressive disease, and approximately half of tecentriq 4-year survivors received treatment beyond progression. So this is an important point to note, that even if the patient has progressed radiologically, and if a patient is showing clinical benefit, then it's a reasonable option to continue the drug till the patient derives clinical benefit. And tecentriq showed a consistent and manageable safety profile with no new grade 4 or grade 5 adverse events reported with long-term follow-up in either study. So to summarize, Oak study demonstrated overall survival benefit in second-line non-small cell lung cancer regardless of PD-L1 expression, and it is approved in all comers PD-L1 unselected patients in second line, and majority of the immune-related adverse events are low-grade and manageable. Now we have one more study to discuss. This is a real world study. This was presented as an abstract in ESMO 2019. So it is called TAIL study. It is a global single arm safety study of tecentriq monotherapy in a diverse population of patients with previously treated non-small cell lung cancer. So this was in these patients stage 3B or stage 4 non-small cell lung cancer that progressed following 1 to 2 lines of prior chemotherapy were included, and they had either squamous or non-squamous histology. And important thing is that patients who had autoimmune disease, they were also included, and patients who had CNS mets, they were also included, and few patients also had EGFR positive mutation that were previously treated with EGFR positive drug. So in this patient, tecentriq was given till loss of clinical benefit or unacceptable toxicity. And the primary endpoint of this study was safety in all patients receiving 1 line of therapy. And the secondary endpoint was overall survival and PFS. So the baseline characteristics of this single arm study was around 615 patients were there with a median age of 64. And you can see both non-squamous and squamous histologies were taken. 75% were non-squamous and 25% were squamous. And in this patient, few patients had also received prior anti-PD-1 therapy. Around 5.4% patients had received prior anti-PD-1 therapy, and few patients had received it with combined with other chemo. Around less than 1% patient had received it in combination with chemo. It had equally distributed patients of who had received more than 1, 2, or 3 line. Around 65% patients had more than 1 line, and we have and more than around 28% had received prior 2 lines of therapy, and it also included patients who had more than 2 lines of therapy, around 6.5%. And EGFR mutation was also present in 6.5%, and PD-L1 expression was also divided. Positive patients were 34%, negative were 27%, and around 38% patients, the PD-L1 status were not known. So important point is that it also included patients with CNS disease, with patients with renal impairment, patients with history of autoimmune disease, and patients with chronic or active hepatitis B and hepatitis C. So most common side effect and tecentriq immune related adverse events in more than occurred in more than two patients, the data is comparable to the clinical scenario that we see. You can see in the left side that the incidence of grade 3 4 side effects, pneumonitis was around 1.5%, and other side effects were less than 1%. The incidence of grade 3 grade 4 side effect were less than 1%. There is mention of grade 5 side effects, and that was probably because of pneumonitis. The other common side effects were hypothyroidism, rash, colitis, adrenal insufficiency, increased OTPT. So coming to the safety profile, patients who had CNS mets, who had a renal impairment, who had a poor performance status of 2, and who had prior PD-1 status, even those patients had similar side effect profile as patients who were uh, as compared to the patients who were included in the OAK trial. So that means that immunotherapy can be given to patients with all these comorbidities. So this is a data which gives us a confidence in using immunotherapy in patients who are renal compromised, who have history of autoimmune disease, who are poor performance status. So you can see that the percentage wise, the side effect profile is similar to patients who had OAK-like population or who had other subsets of patients. So the median overall survival of all patients, that is patients with autoimmune disease, CNS involvement, renal disease, was 11.1 month. And in patients who had the population similar to the OAK-like population, the median survival was 13.7 months. So efficacy in key subgroups. In CNS metastasis, the survival was 5.1 month. We know that CNS mets patient, they don't do very well. And in patients who had OAK-like population was 13.7 months. In patients who had renal impairment had a survival of 13 months. In patients who had poor performance status had a survival of 3.5 months. And in patients who had already received prior anti-PD-1 therapy had a survival of 6.2 months. In patients who had autoimmune disease had a survival of 10.1 month. So this table gives us some confidence that we can use immunotherapy in patients who are renal compromised, who have some autoimmune disease, or who have a poor performance status. So efficacy by tumor PD-L1 expression in patients who had PD-L1 than 1%, around 213 patients were there. The survival was 11.7 months, and in patients who had OAK-like population, that is similar to the population that was included in the OAK trial, it was 15.5 months. And in patients who were PD-L1 negative, less than 1%, the survival was around 8.7 months as compared to 11.7 months in the OAK-like population. And in patients who were PD-L1 unknown, the median OS was 12.5 months as compared to in patients who had OAK-like and had 13.8 months. So what this table is trying to tell that that in second line, irrespective of PD-L1 expression and irrespective of the impairment status like renal impairment, poor performance status, tecentriq can provide significant and meaningful survival benefit to the patients. So summary of primary analysis of TAIL study. TAIL confirmed the safety profile of tecentriq monotherapy in a diverse and previously treated non-small cell lung cancer population. So although it's not powered to draw conclusions from each subgroup, but it provides some valuable information and that can be used in our clinical practice. These safety may inform treatment decisions for such patients, and these data are generally consistent with the published data of checkpoint inhibitors used in populations of special interest, such as patients with performance status 2. And furthermore, TAIL provides novel data on the use of tecentriq in a more diverse population. And the safety and efficacy data in the OAK-like population were consistent with that of the OAK study, including the PD-L1 subgroups. Now, coming to the autoimmune subgroups, I think I have discussed. The important point to discuss in this study was that it had autoimmune patients like psoriasis and rheumatoid arthritis, and the side effect profile in the autoimmune subgroups as compared to the non-autoimmune subgroups that were more or less similar, but It was in fact slightly more on the autoimmune side, autoimmune patients. So the incidence of pneumonitis was more or less same in both the autoimmune and not on non-autoimmune disease patients. And the incidence of pneumonitis, pleural infection, pneumonia, that was not shown for non-autoimmune disease subgroup patient. But we have to err on caution if we are giving a tecentriq molecule to autoimmune disease patient. So median OS was 10.1 month in the autoimmune disease subgroup as compared to 11.1 in non-autoimmune subgroup, and the PFS was 2.9 versus 2.7 months. There is moderate adverse event increase seen in patients with autoimmune disease and tended to be more respiratory in nature or were GI disorders. And these data may inform treatment decisions in patients with advanced non-small cell lung cancer and with autoimmune disease. In the tail studies in OAK, tecentriq has demonstrated an overall survival as compared to docetaxel in patients who are previously treated, either squamous or non-squamous, and has been shown benefit across all PD-L1 subgroups. Despite the high rate of subsequent immunotherapy, a clear OS was seen with tecentriq in both the intention to treat populations. And in tail study, which is a real-world data, survival benefit was observed that is consistent with the phase 3 OAK trial, including across all PD-L1 subgroups. And it also provided data in more diverse population. And tecentriq appeared to be generally well tolerated in patients with previously treated non-small cell lung cancer. And the favorable safety profile of tecentriq was confirmed with increased overall exposure during the secondary analysis. In tail, the safety profile of tecentriq monotherapy was confirmed in a diverse and previously treated population. So presently, tecentriq is approved in first line. That the approval was given in November 2020 for patients who had a PD-L1 expression of more than 50%. It is approved as a monotherapy in lung cancer. And in first line, it is also approved in combination with nab-paclitaxel and carboplatin, and in combination with bevacizumab, pacli, and carbo. And in second line, it is approved irrespective of the PD-L1 status for whether it is squamous or non-squamous histology, provided the patient has received platinum in the prior first line treatment. So there are 4 basic indications of tecentriq in non-small cell lung cancer. So, and it is also updated in also mentioned in the NCCN guidelines that in subsequent second line therapy, nivolumab, pembrolizumab, or tecentriq, any one of these can be given. So with this, I would like to conclude my presentation, and I would like to thank you for listening to my presentation. If any questions from anyone or something needs to be told by the Roche people, they can very well take the dice.
Thank you, sir. Thank you so much for such a lovely presentations. It was indeed very detailed discussions. So if there is any question, please ask.